Hello, everyone. Thank you for joining us today for the Pharmacology series, Updates and Guidelines for Chronic Conditions live stream. This series is a monthly live stream program, which will run from May to September of this year. Each session will be recorded and available on www.nortoncme.com approximately 1 week after the live stream program. And participants will receive a link following program today for an evaluation and for obtaining your CME credit. You can also use the QR code that will be displayed following the live stream after completion of this program. I'd like to now introduce our speakers for today. Rebecca Parrish is going to be our first speaker. Rebecca is a critical care pulmonary nurse practitioner with Norton Pulmonary Specialist. She sees patients in the hospital and in the office with a variety of pulmonary needs. Rebecca obtained a BSN from Bellarmine University and went on to work in critical care and the ICU at Norton Brownsboro Hospital. She later obtained a master's degree in nursing from the University of Louisville and is now a certified acute gerontology, acute care nurse practitioner, and continues to work with the pulmonary critical care team. Our second speaker today is Brittany Wyatt. Brittany is a clinical pharmacy specialist in transitions of care at Norton Healthcare. Brittany obtained her doctorate of pharmacy degree from the University of Kentucky and completed a pharmacy residency at Norton Healthcare in 2019. And she later became a clinical pharmacy specialist at Norton Women's and Children's Hospital. Well, thank you to you both for speaking today. And with that, I'll turn it over to Rebecca to start today's presentation. As a reminder, we will have a Q&A session afterwards. So if you have any questions, please feel free to add those in the chat.
Today's symposium is on COPD diagnosis and pharmacotherapy. I'm Rebecca. Thank you, Kyle, for the introduction. All right, so Brittany and I have no financial disclosures or conflicts of interest over the topics covered in this presentation. Our objectives today are to discuss the diagnosis of COPD, including spirometry and alpha-1 testing. We're going to talk about updated COPD guidelines and recommendations related to maintenance therapy and apply evidence-based recommendations to patient cases. So this algorithm was developed by the COPD task force to help standardize the use of spirometry in our PCP offices. Obviously, if we can detect and diagnose COPD earlier and provide appropriate therapy, we increase quality of life and decrease mortality. If you're in a PCP office now and you're going, where's my spirometry? It's coming. Obviously, COVID threw a wrench in a lot of plans throughout the system, and we're still dealing with some technical and educational hiccups. So we'll break this algorithm down a bit more as we kind of flip through the presentation. What is COPD? It is a common and preventable treatable disease characterized by persistent respiratory symptoms and airflow limitations due to airway and/or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. The next couple of slides, we're going to talk about COPD prevalence and death rate by state. And unfortunately, you're going to see that Kentucky ranks pretty high on both of those. This map was dated back in 2019. And at that time, direct costs of COPD were at $32 billion and indirect costs came in around $20.4 billion. Also, 150,000 deaths were attributed to COPD in that year. Again, Kentucky ranks really high in the death rate by state. And at the time in 2019, COPD was the fourth leading cause of death in the world. By 2020, it is now the third leading cause of death. So COPD is a progressive disease. And as you can see on the left-hand side of the screen, FEV1 is a measurement of lung function. So the longer that you smoke, the faster the rate of lung function decline and the higher incidence of disability and death can occur. Often patients will say, well, I've smoked for 30 plus years, what's the point in quitting now? And as you can see by this chart, if they do quit sooner, they can't prolong their life. So how do we diagnose it? COPD should be considered in any patient who has dyspnea, chronic cough or sputum production, or has a history of exposure to risk factors for the disease. Obviously, spirometry is required to make this diagnosis. You cannot diagnose it with imaging alone. In the presence of a post-bronchodilator, FEV1 FVC ratio of less than 70% confirms the presence of a persistent airflow limitation. So why do we check spirometry? Well, if you test your lungs and know your numbers, you can better direct care and treatment. We test every smoker, 45 years of age and older. And why do we do that, you may ask? Well, COPD develops over a period of about 30 years. So if you had a smoker who started in their teens, around 45 years of age is when you're going to be able to detect early signs of lung abnormalities. A physical exam, chest x-ray, chest CT cannot detect early stages of the disease. If you're noticing emphysematous changes on a chest x-ray or chest CT, you're dealing with a very progressive or late stage COPD. Spirometry, on the other hand, can identify these early onset lung abnormalities. And one single spirometry doesn't give you that much information, but serial spirometry can. So other diagnoses to consider when you're talking about COPD patients, because COPD looks and sounds like a lot of other diagnoses and comorbidities that we see. And a lot of times these patients have concomitant diagnoses. So you should always consider asthma, bronchiectasis, TB, lung cancer, CF, a whole range of ILDs, pulmonary hypertension, obesity, hypoventilation, cardiac ischemia and CHF, upper airway cough syndrome, idiopathic cough, GERD. We all know that medications can cause chronic cough, but so can deconditioning and hypoxia. How do we perform spirometry? First and foremost, please have your patient sit down. The patient should be seated in an upright position. A clip is placed on their nose and they're given a plastic mouthpiece connected to a spirometer or spirometry machine. The patient then places their mouth around the mouthpiece and they're asked to take a big deep breath in and blow it out as hard and fast as possible. We have them sit down because you don't want a patient passing out in your office. And yes, it has happened before. They do vasovagal, and the bigger ones fall harder. So spirometry interpretation, what do we look at when we look at these spirometry results? The first thing we look at is the flow volume loop. Is it normal? Does it look short and squatty like an obstruction, or is it tall and skinny, consistent with restriction? If the results are not reproducible or consistent, make sure you're interpreting those results with caution. When we perform spirometry, they're usually given 3 opportunities to perform it, and they should look kind of consistent across the board. And if they're not, always get a full PFT, or again, just interpret with caution. When looking at that flow volume loop, we can also tell if there is an obstructive or restrictive component, or a fixed variable airway obstruction, something inside the chest or inside the lungs causing an airway obstruction or airflow limitation. So the next thing we look at, in addition to the flow volume loop, are the numbers. FEV1 is that amount of air that you can blow out in the first second of expiration, and FVC, that forced vital capacity, the amount of air you can take in with one big deep breath. If those 2 numbers are normal, then your spirometry is normal. If those 2 numbers have matched deficits, consider restriction and a full PFT to see what's better going on with your patient. If the FEV1 and FVC ratio are less than 70, then we know that obstruction is present, but we need to grade that obstruction and classify their limitation with the GOLD 1 through 4 grading system. So the role of spirometry: first and foremost, we get our diagnosis with spirometry. And second, the assessment of severity of airflow obstruction is going to help better guide our treatment and our therapeutic decisions, whether they're pharmacological or non-pharmacological. sometimes you may have a patient come in and say that they're more and more short of breath. They can't walk to the mailbox any longer. However, their lung function was improved from 6 months ago. Well, that's not maybe a lung problem, and you need to look at other alternative diagnoses. And what I mean by non-pharmacological interventions are things like endobronchial valve placement. It's a means of non-invasive or less invasive lung volume reduction. And then obviously with serial spirometry, we identify rapid decline in lung function. Again, just a quick look at the algorithm as we kind of click through to see how to best manage these patients. So overlap syndrome, some patients have clinical features of both asthma and COPD. And this is called the asthma COPD overlap syndrome, or ACOS. Distinguishing between the two can be problematic, especially in smokers and older adults. The reported prevalence rates for ACOS have ranged anywhere between 5 and 55%, and that varies greatly with gender and age. That wide range reflects the different criteria that's been used by different providers or investigators for diagnosing asthma and COPD. And when I'm talking about an asthmatic component to someone's breathing, what I mean is reversibility. So you really need a full PFT where you've had a bronchodilator challenge to be able to diagnose that asthmatic or reversible component to their breathing. And it's usually at least a 12% increase in their FEV1. So although the initial recognition and treatment of ACOS may be made in a primary care office, referral for confirmatory investigations is encouraged. So referral to the pulmonologist, since outcomes for ACOS are worse than for asthma or COPD alone. So how do we manage this? So as we know, the gold standard of treatment for asthma is ICS. So this absolutely needs to be included in controller medications, and you want to avoid that monotherapy with a LABA or long-acting bronchodilator alone. For patients with COPD, the treatment with bronchodilators or combination therapy is good, but you want to avoid monotherapy with just ICS alone as well. They need something to help keep those airways open and reduce inflammation as well. So for ACOS, you want to treat with an ICS in a low or moderate dose, depending on the level of symptoms and lung function, and then add on treatment with a LABA and or LAMA as necessary. And again, you want to avoid that LABA monotherapy. And this just broke down the algorithm to talk about kind of what we were just discussing on the last couple of slides. All right, so the Modified Medical Research Council Dyspnea Scale, MMRC for short, is a quick little questionnaire that you can give the patient to help classify their symptoms or grade their symptoms. Simple 4-question, 5-question really, because sometimes the patient, if they've been short of breath for years, they may not recognize those symptoms as being a problem. You can ask the patient, do you have trouble walking to your mailbox? And while they're shaking their head no, the family member next to them may be shaking their head yes. So sometimes it's nice to have secondary input when filling this out. So you can take that information, the symptom-based information, combine it with our spirometry information that we got and plug it into that GOLD ABCD assessment tool. And again, this just helps guide our therapy or treatment for the patient. Keep in mind, these are all guidelines. So the next thing we need to talk about when we discuss COPD is something called alpha-1 antitrypsin deficiency. And alpha-1 antitrypsin is a protein or enzyme that is lung protective. And without enough of that or any of that at all, we have destruction of lung tissue that takes place. Because basically we have uninhibited inflammatory mechanisms that happen and over time can lead to very severe COPD. This is a spectrum, however, so you may have a patient who has this and has no symptoms at all or any complications. On the flip side, you may have someone with very severe symptoms, very progressive COPD, and may need a lung transplant. So it's familial, it's genetic. So if there's any family history at all, testing should be performed. And additional testing should be performed if you get phenotypes back on your patient, find out that they are a carrier. They may have additional family members that need to be tested as well. This should be available in your offices. This is what the order looks like in Epic. And I know many of these simple and free tests are provided by reps. So they should be pretty quick and simple in your office. It's just a finger prick. And again, just back to the algorithm, keep in mind that the algorithm is a guideline. It should not ever replace your clinical judgment. And it's never, ever wrong to kind of throw the kitchen sink at someone. If you really don't know or their symptoms are so bad, you can always de-escalate on the back end. You know, I treat patients in the office and the hospital as well. And sometimes when I'm treating an exacerbation in the hospital, I do give them everything and then de-escalate either in the office myself or send a message ahead of time for just plans to repeat spirometry and reassess their symptoms. Oops, sorry about that. So other treatment highlights, obviously we can't talk about COPD without talking about tobacco cessation and ways to achieve it. Inhaler technique. I encourage all providers to learn how to use the inhalers themselves. If the patient is not using it appropriately, they're not getting their medication and they're not going to get better. Obviously, be cognizant of inhaler costs. They're all very expensive. Try to pick what is on the patient's formulary if you can. And I try my very best. Obviously, insurance sometimes dictates what I prescribe. But if you can only use something once a day, it's probably going to be more compliant, or the patient will be more compliant than something they have to use more than once a day. Appropriate patients and appropriate vaccinations are also very important. Oxygen therapy, and I'll talk a little bit more about that here on the next slide. And then end of life. I don't think you can talk about a progressive disease like COPD without addressing end of life topics or issues. Things like EMS, DNR, advanced directives, and hospice when appropriate for the patient. So oxygen therapy, this is what the order would look like in Epic through the Norton DME order. And keep in mind, if you suspect the patient is hypoxic or needs oxygen, walk them in your office. And usually when we walk them, if you have a tank available, it is going to be a tank with continuous flow only. And that's super important because there's a huge difference between a conserving device, pulsed flow oxygen, and continuous flow. Pulse flow conservators oftentimes only go up to 3 liters per minute. So if you have a patient that you know uses 3 to 4 liters continuous flow, that pulse flow conservator is not going to meet their needs. I know it's highly sought after, but insurance also sees the pulse flow conservators as a luxury and not a necessity. So they're oftentimes not covered, and that's a huge expense out of the patient's pocket. So anyway, this is just a nice depiction of what the order looks like in Epic. So this is a nice little graph or picture of all the different classes of inhalers available on the market right now. It also includes some medications for asthma alone. So I have a question here. If everybody wants to take a minute and answer that, and then we'll reveal the answer here in just a second. All right, looks like everybody got it right for the most part. So let's talk about what the answer is. There we go. Okay, so reversible airway obstruction. So this kind of goes back to the slides where we were discussing the asthma and COPD overlap syndrome. You do have an increase in that FEV1. So you have reversible airway obstruction or an asthmatic component to the breathing. And with that, I'm going to pass off to my cohort, Brittany.
Thank you. All right, so now that Rebecca's talked a little bit about COPD, our Norton algorithm, and spirometry, we're going to dive more into the actual medication classes that we use, as well as kind of in the context of the GOLD guidelines there. So when determining actual the medication classes we want to use, of course, we need to take into account the patient's symptoms, like by reviewing the MMRC score with the patient and their risk for exacerbations. And just like Rebecca was talking about, if somebody has overlap symptom with asthma, we also need to take into consideration their comorbidities and think about if that patient needs to be on a steroid inhaler. And then, of course, we can't have a presentation about COPD and brand name medications without talking about the drug availability and the cost of the medication. And then, of course, we always need to be thinking about the patient's response and de-escalating when appropriate and changing up therapy when it's needed. And then think about our patient's ability to use different devices and their preference for maybe a powder inhaler versus a aerosolized inhaler. So we're going to talk about the different medication classes in the context of the GOLD guidelines here. And there have been many kind of recent updates to the COPD guidelines for initial treatment and follow-up treatment, and just reviewing and assessing, as well as some primary literature that has come out recently. So we're going to start with the initial treatment algorithm. So for patients in group A, these are patients who have low symptom scores, so either a low MMRC or low CAT score, as well as having 0 or 1 moderate exacerbations that did not lead to a hospitalization. For these patients, a short-acting bronchodilator would be appropriate. So short-acting bronchodilators include antimuscarinic inhalers as well as beta-2 agonists. You can see the names of the agents here on the screen. Short-acting, these agents are very effective at improving lung function and reducing symptoms. And short-acting bronchodilators are dosed every 4 to 6 hours. The adverse effects are listed on the screen, not anything that you all wouldn't expect from talking with your patients. And then usually long-acting agents are recommended unless the patient only has occasional symptoms. And then in that case, you could consider just using a short-acting bronchodilator. And then all patients should have a short-acting bronchodilator to use on hand too, in case they have emergencies, they need that rescue inhaler. So now we're going to move on to group B. So these patients still have a low exacerbation risk, but they are more symptomatic according to their MMRC or COPD assessment test scores. So in these patients, we generally use a long-acting bronchodilator. Long-acting beta agonists and long-acting antimuscarinics are generally dosed 1 to 2 times per day and have similar adverse effects to their short-acting counterparts. Dosing and adverse effects, of course, are important to consider when thinking about our patients and considering our patient adherence. And then this slide highlights the different bronchodilator products that are available. And usually insurance will cover at least one medication in each class, sometimes not all of them. And sometimes we are at the kind of the mercy of the insurance company for what gets prescribed and what our patients are going to ultimately be on. I will say for the LAMA inhalers, I think pretty regularly, at least in my setting, we're seeing Spiriva, whether that's the Respimat or the HandiHaler, and then Incruise is our maybe most common ones we see covered on the insurance here. So next we're going to talk about our group C patients. So these patients have a high exacerbation history, including 2 or more moderate exacerbations, or even just 1 exacerbation that leads to a hospitalization. And then LAMA therapy is recommended for these patients. So to examine LAMA therapy more closely, we have a New England Journal of Medicine study that took place over 4 years that compared tiotropium, which is the generic name for Spiriva, versus placebo. And this study found that therapy with tiotropium was associated with improvements in lung function and quality of life and decreased exacerbations during the 4-year period. And patients, I just like to point out, especially because I am in the hospital setting, that if you've had a patient who's been admitted to the hospital with a COPD exacerbation, they should likely be on a LAMA inhaler therapy. Like, that's something we should be thinking about, kind of assessing and adding on to their treatment if it makes sense. So now we're going to talk about initial therapy for our group D patients. These patients are both highly symptomatic and have high exacerbation history. So these patients have a lot of options for what they can be treated with. They might be treated with a LAMA or a combination LAMA-LABA inhaler, or maybe even a combination ICS-LABA inhaler. So when you review the primary literature, you find that LAMA and LABA combination therapy is superior at reducing symptoms than monotherapy alone. And then ICS-LABA inhalers are also decrease exacerbations when blood eosinophils are elevated, but the ICS inhalers do carry a risk of pneumonia. So that is something we want to think about too. So in summary, if you have a group D patient with starting initial therapy, you might consider a LAMA inhaler. If they're highly symptomatic, you might add on LAMA-LABA. And if their blood eosinophils are elevated, or if they also have asthma, at that point you would consider the ICS-LABA inhaler. So here's a list of the combination bronchodilator products. So I see most often probably Stiolto and Anoro. Every once in a while, you'll get somebody whose insurance prefers the Vespi inhaler. And then here's a list of the inhalers that contain inhaled corticosteroids. These include, I think what we commonly see is Trelegy, Breztri, Symbicort, Advair, Breo. These are maybe a little bit more common to see because these are used for patients who have asthma and COPD. And generally, like we said earlier, insurance will usually cover one product at least out of each of these categories. Sometimes a prior authorization might be necessary if you're going for triple therapy. So the LABA, LAMA, ICS inhaler, sometimes the insurance does want a little bit more information about that one. And I will say with the inhaled corticosteroids and the combination products, not all the doses are approved for COPD. So you might just double check if you're unsure in a drug reference, which dose is right for which inhaler when you're picking the inhaler for the indication of COPD. So next, we're going to review a patient case. So ST is a 60-year-old male with a past medical history positive for hypertension and tobacco use. He is admitted to the hospital with a diagnosis of a COPD exacerbation. You can see his MMRC is 1, his CAT score is 7. You see his FEV1 over FVC there, and he has 0 blood eosinophils. At home, he's only on low start and a multivitamin daily. He doesn't have any allergies to medicines. So at this point, what therapy would you consider for a COPD maintenance inhaler? And then if you want to put in the chat box what other therapies you might consider for this patient when he's leaving the hospital as well, you can feel free to do that. Okay, so we're maybe a little bit more split across the board here. But I'll kind of explain what I would maybe recommend and why. It's always weird after the question is. Okay, there we go. So this patient has a low MMRC and CAT score. He still falls into that lower end category, but he does have a an exacerbation that led to a hospitalization. So this patient I would place in maybe the group C category and consider a LAMA inhaler for him. And then additionally, I would probably consider providing him with a rescue inhaler, assessing his willingness to quit smoking with some tobacco cessation therapy. And not on the slide, but of course you'd want to treat his current exacerbation, whether that's with steroids or antibiotics, whatever was appropriate there. So now we're going to talk about follow-up therapy. So we've already started our patient on their initial therapy, and they're in clinic for a follow-up. Like, how are we going to change their therapy? So you do want to assess their response to a LAMA or a LABA if that's what they were on. If they are not well controlled, meaning they have 2 or more exacerbations, or maybe they have an exacerbation leading to a hospitalization, or if their blood eosinophils are greater than 300, those are all things you would look at. If they do not have any of those, then you might move to LABA-LAMA combination therapy. And if they did have any of those, then that's the point where you might consider adding on the ICS-LABA therapy to their regimen. If they're still not well controlled, then that's when we might move to triple therapy. So this is a study that we have that looks at ICS-LABA-LAMA therapy compared to dual therapy. And I think it kind of helps us tease out which patients we might want to start with just LABA-LAMA and what patients might really need that ICS inhaler, and kind of thinking about which patients we might want to de-escalate off certain inhaler types, maybe specifically ICS inhalers. So this study compared combination therapy ICS LABA-LAMA versus LABA-LAMA solo. And they did find a decreased risk of exacerbations leading to hospitalizations. But like we discussed earlier, there is an increased risk of pneumonia when patients are using ICS inhalers. So that's really why when we're kind of looking at the guidelines and, for certain patients, it's not always appropriate just to jump to that, all 3 inhalers all at once. And then to zoom in a little bit closer at the pneumonia risk, several other studies have been conducted to evaluate the pneumonia risk with the inhaled steroids. And these are some meta-analysis that are listed on the bottom of the slide. So this is considerations of when to use an ICS inhaler and maybe when to avoid use. So we have strong support if a patient's had 2 or more hospitalizations from a COPD exacerbation, if their blood eosinophils are greater than 300, if they have that history of also having asthma, then that's when it makes sense to definitely use the inhaled steroid. You might consider it if they're having 1 or more exacerbations per year, just by being on bronchodilator therapy, or if their blood eosinophils are mildly elevated. And then times to consider avoiding use would be if they're having repeated pneumonia events, if their blood eosinophils are less than 100, or if they're having a history of mycobacterial infections. So this slide came from the GOLD guidelines and pretty much just reiterates what we were talking about. And this is a little bit of an update in the recent guidelines and a change of thinking. So several inhaled corticosteroid withdrawal studies have been conducted, and they didn't find an increased risk of exacerbation with COPD when you were pulling the patients off the inhaled corticosteroids. So it's not something we would need to worry about there of, if we pull off the ICS inhaler, are we going to have our patients have worse outcome? We have some studies that show that that does not appear to be the case. So then we do have some additional therapies that we might consider for patients. If you're getting to this point, though, I think maybe having a pulmonologist on board or kind of discussing with your other colleagues wouldn't be a bad idea. So you can consider medications like roflumilast if the blood eosinophils are less than 100 and the FEV is less than 50%. And then you can also consider azithromycin in former smokers additionally. So roflumilast is a medication that has a lot of drug interactions. You start with a dose of 250 milligrams once daily for 4 weeks to assess tolerability, and then increase to a dose of 500 milligrams once a day. And always be checking your drug information references or checking in with your pharmacist about medication interactions, because significant interactions do exist. And then long term, I would say we don't see this too often, but there have been some studies that look at azithromycin in former smokers and as a potential option. But again, I probably would have a pulmonologist on board with this or have somebody kind of on the team helping with this. So that brings us to our second patient case. A new patient, JM, presents to your office after being admitted to the hospital for an exacerbation. You note that he's currently on a maintenance inhaler with Symbicort, 2 puffs twice a day, and he's taking the medication appropriately. So what information would you assess to determine if this therapy was appropriate for him? So we'll open up the poll. Okay, great. So that's the answer I said too. D would be the correct answer. We would want the eosinophil count, the symptom assessment scores. We'd want to know his response to his Symbicort, and then we could move forward from there with our decision. So here's the information we found out. His MMRC is 2, his CAT is 15. His eosinophils remain at 0. Since his previous hospitalization, he has now had an additional exacerbation, and he was treated outpatient for pneumonia last month. So how might you decide to change his inhaler therapy? Okay, so I actually said that we would probably want to consider de-escalating him off the steroid at this point because he has had the exacerbation for pneumonia and his eosinophils are 0. So what I said would be the best option for him would be to change to B, Stiolto, which is a LABA-LAMA combination therapy. So in addition to kind of choosing the medications, we also have to be mindful of our patients, and it's not always just about prescribing the best medication or, even getting it in their hand. There's a lot of other barriers that we need to mitigate for our patients here. So the ones I highlighted and that we're going to talk a little bit more about through the end of the presentation would be educational barriers, administration technique barriers, and then the affordability of the medication. So to mitigate educational barriers at all stages of treatment, we should be using open-ended questions to assess how they're using their inhaled medications, and really asking them to provide the dose and the frequency versus saying, oh yeah, you're still taking your Symbicort, right? So making sure that they're actually using it the way they're supposed to be taking it, and make sure they know how to use the different inhaler devices. I think an example of this, and it's important for us to know too as practitioners, even if somebody is using Spiriva, we need to know if they're using the hand inhaler versus the Respimat, and if they actually are kind of using those devices correctly, because different counseling points and different education is going to be given depending on which inhaler device the patient is using. And then I know we've all had those patients who are taking their maintenance inhaler just when they need it, or using their rescue inhaler on their regular basis. So always double checking on that and educating patients about the differences between their maintenance inhalers and their rescue inhalers is going to be key. And then reminding patients to rinse their mouth out after they use steroid inhalers to keep them from getting thrush infections. So administration technique was actually added to the guidelines starting in 2019. And we did find a study that showed that more than 2/3 of patients have issues using their inhaled device. But luckily for us, we did find that using the teach-back method did help patients use their inhaler correctly. So if you have those demo devices in the office, or maybe even if you have a pharmacy colleague in the office who can kind of help use that teach back method for the patients, that's really key for helping our patients moving forward. And then this is just another slide that kind of highlights all the different devices that patients might be using, and knowing that there's different directions for each type of inhaler device. So becoming familiar with the directions and maybe the differences between these different devices, so that way you can really make sure your patients are using them correctly and that you know how to provide education on these inhalers as well. And then financial barriers. So this one is huge because a lot of these inhalers are brand name only medications. Some of our patients are fixed incomes. So kind of knowing the different things we can do to help them and the different resources that are available. So through Medicare, there is a program called Medicare Extra Help. This is something that patients can apply for online, over the phone, or through the Social Security office if they meet certain income requirements. And that usually will, depending on their tier, but what we've seen is sometimes it brings the copays down of their brand name medicines to about $10 per month. So that's always a good option if you think somebody has limited resources and they're on Medicare. There are also websites like Fingertip Formulary or needymeds.com, and these can help you determine the formulary agent that the insurance is requiring. So sometimes when you get those PA requests for Spiriva, it might be as easy as, just checking in with the pharmacy to see, or checking in with needymeds.org to see if there's a different medication that's approved on their formulary. And that might just be an easy switch. That way that patient can get started on therapy. And of course, each Norton hospital does have a Norton pharmacy campus, and our pharmacists are really accessible too. So if there's a patient who is agreeable to using Norton pharmacy, always, have to put in my plug that our pharmacists there would be more than happy to help you out with figuring out which one was going to be affordable, doing test claims and figuring out things like that as well. There's also a Norton financial assistance program that patients can apply for if they have limited income, if they're underinsured. So that would be something that patients could potentially look into as well. And that would cover medication costs at the pharmacy. And then if patients are commercially insured, they can use copay cards. So that's the kind of great offers you see or maybe get in the office where it says pay as little as $0. Of course, there are stipulations with those. So, always keeping that in mind. And that cannot be used for Medicaid or Medicare patients. There are some free trial offers that can be used as like bridge therapy. So if you have a patient who, is getting insurance next month but needs something this month, those offers may be available. And then there's also manufacturer assistance programs, which does require a little bit more paperwork on the front end and is maybe not the quickest process. But if your patients do qualify, then they get free medication sent from the manufacturer's office. In my current role, I usually provide patients with this paperwork and encourage them to kind of bring those resources to their outpatient providers. So that way you all can kind of work with the patients to figure out if that's really the best therapy for them, or if they should be switched to something different, or what the best options can be moving forward. I guess I will say as well, if Medicare patients don't have a Part D prescription insurance coverage, some nebulized medications are covered under their Part B insurance plan. So if you have a patient who needs maintenance therapy, switching to the nebulized form, LABA, LAMA, ICS, whatever it might be, is sometimes more affordable for those patients who don't have prescription insurance coverage. And then we touched on this a little bit, but of course, with smoking cessation, that's definitely something you need to be considering for our patients with COPD. We have the 5 A's: ask, advise, assess, assist, and arrange. And we have pharmacotherapy like nicotine patches, nicotine gum, Wellbutrin. Chantix is actually on back order right now, so that's not the best option at this time, but that is, another option we have in our tool belt usually. And then at our Norton pharmacies, we can help patients get nicotine patches, nicotine gum through our board approved protocols. So that would also be an option, as well as Norton host freedom from smoking classes that are good for patients if they're kind of motivated to quit smoking and want to do so in that group setting. Then there's the 1-800-QUIT-NOW national hotline number that's available for other patients as well. And then we also, of course, need to be thinking about managing their other conditions. So if patients are regularly getting steroid packs, that might be detrimentally affecting their osteoporosis or their heart failure. So really trying to get patients stabilized on the right maintenance therapy is going to be key. So that way we can kind of avoid that extra steroid use and hopefully help them out. And then, of course, vaccinations. So our influenza vaccines annually, our pneumococcal vaccines, and now we've got our COVID vaccine to also add to our list here. So in summary, exacerbation history and symptoms should be continually assessed to determine if patients are on the most appropriate maintenance therapy for each individual. And key considerations in COPD include, of course, appropriate diagnosis and testing with spirometry and alpha-1 testing, selection of appropriate maintenance therapy, barrier mitigation, whether that's financial, adherence, or educational barriers, smoking cessation, immunizations, and then medication and condition management. So I think that brings us to the end of our slide deck here. So we'd be happy to answer any questions for y'all.
Real quick before we get to the questions, I would be remiss if I didn't say thank you to Dr. Hasselbacher, who lended us the COPD didactic portion of our talk today. He recently did a presentation himself. And if you're looking for additional pulmonary CME, you can check out his presentation that includes more information on asthma as well, Pulmonary Pearls. It's on the Insight CME website as well. Thank you.
Well, thank you both for presenting today. It was very informative, and I know we've got some good questions here, so we'll get into that real quick. First question was, in patients receiving an inhaler, is rebound anxiety a commonly experienced adverse effect, or for those with anxiety, is there a best choice for inhaler?
I think when you have COPD in general, there's going to be anxiety, and I don't know, to my knowledge, that there's going to be a specific inhaler that can help or prevent that. But talking with your patient about whatever you're putting them on and making sure not only the appropriate inhaler, but do they need oxygen? Are they feeling anxious because they're hypoxic? Are they feeling anxious because maybe they don't get out of the house and they don't have that socialization anymore? So pulmonary rehab, which we really didn't touch on during the presentation, but in addition to inhalers and oxygen therapy, pulmonary rehab can help reduce risk of mortality as well. And it's also social. So you're getting out and you're socializing and working your lungs with people who are going through the same thing. So sometimes just that camaraderie, so to speak, can help with that anxiety.
Excellent. Thank you for that. The next question we have also is for adverse effect is, what is the best choice of inhaler for someone who has a tremor as a side effect?
We could potentially, like for rescue, you could consider the levoalbuterol or the Xolair. That may have a little bit less of those somatic tremor effects.
The next question we had was, talk to us about best ways to enhance adherence and medication compliance and limit need to move to a more complex medication regimen or treatment regimen.
Well, like I stated earlier, you want to pick, if you can, if insurance allows, the less times you have to use a medication a day, the more adherent or compliant the patient's going to be. Insurance doesn't always let us do that, but maybe tying that inhaler use to brushing your teeth. If it's a twice a day medication, put your inhaler next to your toothbrush. And because if it has an ICS in it, you want them brushing their teeth or rinsing their mouth afterward anyway. So tying it to something that they do daily already can help with that.
Yeah.
Absolutely.
Next question we had was, talk to us a little bit about how to, or I guess for our primary care colleagues on the call, talk to us about when to refer, when is it appropriate to refer a patient to pulmonology, and talk to us about kind of complexity of care and how that relates.
Either one here, I think. So if you're having trouble getting a hold of the patient's symptoms or their lung function is progressing faster than you can kind of keep a hold of, refer out. We would much rather get a patient, what we call too soon, than too late, when we can't affect change any longer. There's nothing worse than getting a patient with very progressive or end-stage disease where the only thing you have to offer them is hospice care. So we'd much rather get a patient on the front end if they're willing to come see a specialist.
Certainly. And then last question was for Brittany on the pharmacy side. When and how can we incorporate pharmacy into this overall treatment strategy for COPD patients? And then can you talk to us about some of the resources within Norton Healthcare that we have?
Absolutely. There is a pharmacist there's pharmacy coverage, I guess, in the Audubon NCMA office. So if you do know that you have a pharmacist over there, the pharmacists who work in that office would be more than happy to help with assessing adherence technique, doing follow-up calls, things like that for our patients. And then in the Norton pharmacies as well, the pharmacists are very accessible. So if you know a patient's been maybe having a hard time with affording their medications or having a lot of questions about using their medications, then we would also be happy to see them at the Norton pharmacies and help them out with that as well. In addition to your outpatient Kroger, Walgreens colleagues, they're pretty busy, but they also are trained and know how to use these devices as well. So always looping them in is a great option. And then what was the second part again?
We talked about what options are available with Norton Healthcare, and then how do you loop in your pharmacist if you're in either primary care or a pulmonary office? What's a good time for them to kind of join in management? And then how do you incorporate in your overall treatment strategy?
Yeah, I would say we, as pharmacists, when we're kind of in the office, we get looped in on patients a lot who are having financial barriers. That's something that we definitely help with. And if there's any sort of educational barriers, or if that patient needs maybe a little bit more motivational interviewing for like reminding them why they want to take their inhaler and the importance of taking their inhalers every day. So we're more than happy to help with those kind of check-ins or in between visits, or maybe spending a little bit more time if the patient needs it for the teach-back method on how to use the inhalers.
Great, thank you. Well, I think that concludes our question and answer session. Anything else from Brittany or Rebecca you'd like to add?
You know, I do see actually Dr. Hasselbacher made a comment.
Was there one more?
Well, he just, it was a quick comment, and I agree. Oftentimes we don't have the data in the hospital or the hospitalized patient to rule out ACOS. So again, discharging that patient on aggressive therapy and then de-escalating as an outpatient is very appropriate.
Yes.
Perfect. Thank you all for catching that.
Yeah.
All right. Well, anything else you two have to add?
No, thank you all very much.
No. As a reminder, you're going to receive a link to an evaluation for credit. In addition to an email, when you exit this webinar, you will see a link to SurveyMonkey. Select the continue button on there for the evaluation and credit portion. Please join us also for our next session in the Pharmacology series live stream on Thursday, June 30th at noon. The session will focus on hypertension, and we'll have further communication coming about subsequent sessions as well. Thank you again for joining us, and everyone have a great week.